Welcome to The Explainer. Today we're doing a really high-yield clinical refresher on small cell lung cancer. We're going to focus on those key decision points, the things that really matter in diagnosis and staging for us as practicing oncologists.
All right, so here's how we'll break it down. We're going to walk through the clinical journey, starting with the disease's aggressive personality, then how patients actually present, how we lock in the diagnosis with pathology, and finally get into staging and what it all means for prognosis.
So, first things first, let's really set the stage with the core identity of SCLC, because this is what drives pretty much all of our clinical urgency.
Now this number, 67%, it's a stark reality, isn't it? It means the majority of our patients, about 2/3 of them, are walking through the door with disease that has already spread. And that single fact right there frames every single decision we're about to make. It puts us on the clock from minute one.
As we all know, this aggressiveness comes from its biology. It's a neuroendocrine tumor. And that isn't just a classification. It's the engine. It's what's behind that incredibly fast cell division and why it loves to spread through the bloodstream so early, often way before the symptoms even get severe.
Okay, so let's move on and see how this aggressive profile actually translates to what we see in the clinic or a lot of times in the emergency department. When you look at the chest, the classic picture is this: a big, bulky central mass that's probably pushing on everything around it. And that's exactly why we have to be on high alert for those oncologic emergencies, like superior vena cava syndrome. Sometimes that's the very first sign. And this is one of the most fascinating and defining features of SCLC. It's its ability to act like a rogue endocrine organ. The tumor itself is pumping out hormones, making antibodies, and creating these really complex paraneoplastic syndromes that can honestly be the very first clue that something is wrong.
So the key takeaway here is pretty clear. The way the patient presents can totally mask that the problem is in the lungs. They might show up with dangerously low sodium or some bizarre neurologic symptoms, and suddenly we have to put SCLC on the differential for what looks like a complex endocrine or neuro case.
So once SCLC is on our radar, whether it's from a scan or some of these strange systemic clues, the absolute critical next step is getting that tissue and confirming the diagnosis.
Under the microscope, the features are just classic. For any pathologist, this pattern is unmistakable. You see these small, tightly packed blue cells. They have hardly any cytoplasm. They're pressed up against each other, so you see nuclear molding, and the mitotic rate is through the roof. It's the first visual proof of just how aggressive this thing is.
But it's the immunohistochemistry, the IHC, that really cements the diagnosis for us. When synaptophysin or chromogranin light up, that confirms the neuroendocrine origin we've been talking about. And then you see a Ki-67 index north of 80%, and that puts a number on the rapid-fire proliferation we're seeing clinically. It's the molecular proof.
Okay, the diagnosis is confirmed. Now, our focus has to shift immediately. We need to define the extent of the disease, basically define the battlefield, and make sure we've ruled out its key mimics.
For all its complexity, the staging for SCLC is actually pretty simple and powerful. We use the two-stage system. And it all boils down to a very practical question. Can we safely target all the cancer we see with a single radiation field? If the answer is yes, we call it limited stage. If it's no, it's extensive. Simple as that.
Now, to answer that staging question, you need a specific workup. The PET-CT gives us that whole body picture. But, and this is critical, it has to be followed by a brain MRI. It's mandatory. SCLC just has such a high tendency to go to the brain that CNS screening at diagnosis is absolutely non-negotiable, even if the patient has no symptoms. Okay, but before we lock in that treatment plan, we have to pause and address a really key diagnostic challenge, and that's distinguishing small cell from its close cousin, large cell neuroendocrine carcinoma. Getting this right is critical, because the treatment pathways are completely different.
Now, they're both high-grade neuroendocrine tumors, but a good pathologist can tell them apart. LCNEC, as the name implies, has larger cells, more cytoplasm, and these really prominent nucleoli. And making that distinction it's mission critical. It's what decides if we go with a classic small cell regimen or something that looks a lot more like a non-small cell protocol.
All right, finally, let's talk about the factors of diagnosis that help us frame the prognosis, the things that help us have those really important, really difficult conversations with our patients.
It's no surprise that stage, limited versus extensive, is the #1 predictor by far. But after that, you've got to look at the patient's fitness, what we measure with the ECOG score, and the total burden of disease, which is often reflected in something like the serum LDH. These are all critical, independent pieces of the puzzle. So,
At the end of the day, when we're thinking about prognosis, it's a synthesis, right? It's a combination of the disease biology, how much tumor there is and where it is, and the patient's own physiology. Can they actually withstand the aggressive treatment this disease demands?
And that really leaves us with a forward-looking thought. We're learning so much more about the different molecular subtypes of SCLC, so the big question is, how do we start integrating that data to move beyond our classic factors, like stage and LDH, and build prognostic models that are truly personalized? Something to think about. Okay, that's our SCLC refresher.